What is clucking a patient? Clucking a patient is the first and the most important contact that any medical student has with his patient. Okay, the main purpose of this clucking is to obtain a detailed history of his symptoms and perform a physical examination on him to elicit the signs that he may have. With the symptoms and signs collected, you should then come to a reasonable and logical provisional diagnosis and a couple of differential diagnoses. Before, before we move on, what are the right attitude of a student be to his patient? First, you must have the right attitude of yourself too. You may be there's some fear and anxiety on encountering a patient for the first time. But if you get started with the right attitude and in some special efforts to know your patient first, the rest will fall in place in due time. Secondly, right attitude towards the patient is essential. And the 3 C's attitude of courteous, concern, and compassionate will go a long way to facilitate your relationship with your patient. At times, the patient's abnormal patient reaction is at times exhibited by the patient. They become uncooperative, indifferent, and even angry with you. This is due to the fear and anxiety, due to the uncertainty, the disease, and the possibility of death. The patients are humans with emotions and feelings like every one of us. There are some unwritten rules which you must adhere when dealing with your patients. First, the patient is always right as far as his illness is concerned. Second, the patient knows his illness best. Treat his information with utmost confidentiality. Always respect his decision on treatment options. And lastly, treat always, cure sometimes, but never cause harm at any time. Okay. Now we come to some common symptoms in surgery. First, in the history, the most important symptom in surgery patients is pain. Okay, it's the most common. Over 90% of patients present with pain in some form or another at some site and with different severity. It is very important to document the onset of the pain, the duration, progress, radiation, severity, and aggravating and relieving factors of this pain. The second most important symptom is a complaining of a lump, mass, or swelling in some part of the body. Again, it is important to address this onset, the duration, whether it is localized or diffuse, associated swelling or edema, the skin changes, and also the color of the skin overlying the lump. The third common symptom in surgery is bleeding, and this can be hematemesis, the vomiting of blood, melena, passing of black stools, stale blood or black stools in stools, hematuria, passing of blood in the urine. In any of these conditions, all these conditions, it is important to document the amount of blood, the color of the blood, the presence of clots, and whether it's associated with pain or otherwise. Other less common presentations include ulcer, sinus, and fistula. Okay, again, it's important for if these symptoms, you have to ask for the site of the ulcer or fistula, the size, shape, ages, the base and the edges, especially in ulcers, and the surrounding changes in the skin. Next is discharge, and once there is some discharge, it is important to document whether it is serous, pus, mucus, or blood. Bloodstain discharges are always very significant because it could be the precursor or to a malignant lesion underneath. Fever is another common symptom, and in fever, you must always uh, describe the nature of the fever and its association with either it is chills and rigors, okay, and sweating. So these are important aspects of the fever that you must document. And lastly, nausea and vomiting, especially for abdominal cases, you must always look for the contents. What are the contents of the vomiters? The color of the vomiters, whether it is projectile, and its frequency and severity. In all these symptoms, it's important to always find out the duration of the symptom, the nature of onset of the symptom, whether it's acute or chronic, and whether it's progressive or regressive. In pain assessment, the mnemonics used is Socrates, okay, which refers to site of pain, onset, acute or chronic, character of the pain, radiation of the pain, other associated symptoms with the pain, the timing of the pain, okay, the time frame of the pain, and exacerbating and relieving factors and severity of the pain. The common signs in surgery that we see in our patients. Okay, lump, mass or swelling, tenderness or pain on pressing the abdomen, jaundice, pallor, guarding, loss of function, edema and ascites, wasting, emaciation or cachexia. And whenever you notice a lump or mass or a swelling, important, very, very important for you to locate, describe the site of the lump, size, shape, consistency, the margins, mobility with respiration or fixity and tenderness. So these are the important, most common sign is lump. You must be able to determine these features. Next, we come to the format for the clucking of a surgical case. Okay, first you have history, the case history. In the history, the identifying data is very important. In particular importance is the age of the patient. Okay, it's very important to document the age of the patient. Others important features will include the chief complaint or complaints in chronological order if there are more than one complaints. The chief complaint is the complaint that brings the patient to the hospital or the doctor. Subsequently, you go into the history of present illness in chronological order. Arrange the symptoms in the patients in order chronologically or in chronological order. Then you have to look into the relevant associated positive and negative symptoms. A review of the system, get a few symptoms from each system to see whether it is normal or abnormal. ONG history, especially in women at risk. Past history is very important, and in surgery, medical and surgical histories are important, and in surgical history, you must try to get details of surgery done, if any. Okay, when was it done? What was the surgery? And were there any complications? Drug history, allergies, drugs and dosages, if possible, must be tried as hard as possible to get from the patient or the relatives. The family history is important, especially in some cases, tumors, like colonic tumors, which tend to run in families. and of course go into the complete nutritional and diet history, the social and occupational history as well. Having got this case history, then we go into the physical examination. Physical examination, which involves general inspection, looking for pallor, nutritional status, any jaundice, anemia, and then you look for the vital signs, blood pressure and pulse rate. Okay, then you look for relevant signs in relation to the chief complaint. Okay, the chief complaint is vomiting of blood, then look for signs of anemia. Local or specific examinations in relationship to the chief complaint. Okay, look for example, if it's an abdominal pain, then you look for examine the abdomen for specific signs in the abdomen. And then review of the system, review examination of all the systems from head to toe. Okay, after the history and examination, we continue with uh, the formatting. We look for the clinical summary. Okay, you provide a short clinical summary which includes the important features in the history and physical examination. It should be short and precise in about 5 to 6 sentences. From this is clinical summary. You go on to provide a provisional diagnosis, which is the most likely diagnosis based on symptoms and signs in this patient. At the same time, you should be also able to give at least 3 other possible differential diagnoses for the patient. After this diagnosis is entertained, then you go on to investigate, to the investigations to confirm or exclude your diagnosis. Okay, it is always important to start with the least invasive, uh, less affordable, and least or no complications, little or no radiation, and easily availability. These are important things must consider when you order your investigations. And these can be blood investigations, urine analysis, imaging such as X-rays and ultrasound, or it can be endoscopic and or other forms of biopsies, tissue biopsies to confirm the diagnosis. So after the investigation, you should derive at the final diagnosis from the investigations. And once the final diagnosis is finalized, we may go next into definitive management and treatment of the patient. Always have an outline plan for the patient's treatment. Okay. For convenience, the abdomen can be divided into 4 large quadrants. Okay, here you've got a right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. Okay, and each of these quadrants contain the various important organs within. In the right upper quadrant, the 3 main ones are the liver, stomach, and the gallbladder, and part of the duodenum. And in the left upper quadrant is the stomach, spleen, and the pancreas. The right lower quadrant, appendix, right colon, and right ovary in females. And in the left lower quadrant, you have the colonic diverticula and the left ovary in females. It also carries your descending and sigmoid colons in the lower abdominal, left lower quadrant. The kidneys, on the other hand, occupies both the upper and the right quadrants on either side, on the right and left. Slide summarizes the 10 steps to a diagnosis. First, get the chief complaint and consider the possible causes. Okay, age, sex, chief complaint, duration. Number 2, get a detailed history in relationship to the chief complaint, details of chief complaint. The third, list the possible symptoms and signs and relevant negative symptoms. Okay, this is very important. Fourth is the possible diagnosis from the history. Fifth, examine the patient thoroughly, general as well as specific or localized examination. Step number 6, list the positive and relative negative signs and symptoms. Step 7, clinical summary and provisional diagnosis. Step number 8, differential diagnosis. What are the differential diagnoses? Number 9, the investigations that you want to do for the patient. Review the investigations done and what would you like to do further. And finally, the final diagnosis after the investigations, by reasoning and by exclusion, determine the final diagnosis. So these are the 10 steps that you must remember to a diagnosis. Okay, in part 2 of today's series, I call it the clinical case scenario, or in short CCS. And this is how the patient presents to you with this particular disease. So every problem, every disease is presented very much differently by the patients. So he presents as a puzzle, which as doctors and medical students, you got to solve this puzzle by various techniques that I'll describe to you. Okay, so this is part 2, called clinical case scenario, solving the puzzle. Okay, the first thing that the patient, when you approach the patient, is to get the history. Okay, the history is a very, although it is very simple, but it is the most important part of the examination. Okay, and the history is headed by the question, what is the chief complaint? So the chief complaint is a very important thing that you must be very particular and ensuring that you get the right chief complaint which brought the patient to see the doctor for admission. Once you got the chief complaint, then you list straight away in your mind, you must list all the possible causes of this chief complaint that may be in this patient. So next we come to the history of present illness. Okay, a detailed description of the patient's illness that brought him to the hospital. Okay, so once you get the history of present illness, you go through the issues and pointers from the history of present illness. Okay, you identify the issues or the pointers from the history. Positive and negative symptoms must be looked for. Okay, not only the positive symptoms are very important, you must identify the positive symptoms, and more importantly, equally important is the relevant negative symptoms, which is not present, but you expect which is not present in the patient. Next question to go through is what further investigations or what further questioning that you need to undertake to get more information to describe the symptoms that the patient already complained of. And once you have this in your mind, then you list the possible diagnosis from the history of present illness. Okay, so in your mind you have a few diagnoses which are possible in that particular patient. Next you come to the physical examination. This is also a very important part of the physical examination. Okay, so you try to look for signs in the patient in relation to the chief complaint and the history of present examination, present illness. Again, look for the issues and pointers from the physical signs, which can lead you to the diagnosis. Positive and negative signs must be looked for. Okay, positive signs, definitely. What are the positive signs that you will look for in this patient? And also the relevant negative signs. That means the signs that you expect the patient. For example, a patient with right hypochondrial pain. You expect to have jaundice. And the patient is not jaundice. So this is a relevant negative sign. Then, of course, you may want to know some of the signs which is not there. So you want to ask further, examine further sometimes, especially when you're clerking a patient, you might have missed in the first round of examination. So you go back to the patient and ask, find out what are the further signs you want to need to look for in these patients, which you have not done so in the first round. And then at the end of all that, you come to a diagnosis, which can exclude from the physical examination. Okay, from the list that you created from the history, what are the few that can be excluded after the physical examination? After getting the history and done a physical examination, then you must come up with a clinical summary, which consists of both history and examination. Okay, and then it should be short, preferably within 5 sentences. Okay, and you must include the history and the physical examination findings, and mainly positive and symptoms and signs and relevant negative signs and symptoms. These are important. So these are the important things which you must come together, derive at after history and physical examination. With this summary, then you proceed on to derive at the diagnosis. You have a provisional diagnosis, which is the most likely diagnosis in that particular patient of yours, and a differential diagnosis, which can be also other alternatives, which are also possible. So first, you look at the provisional diagnosis. And this provisional diagnosis must be based on the symptoms and signs of your patient, not textbook signs and symptoms. Diagnosis must be common or prevalent in our country. There's no point diagnosing inflammatory bowel disease in our country, which is very, very, very rare. And the cases must be derived at with the symptoms of the patient, not manufactured symptoms, but genuine symptoms from the patient. Then, so the provisional diagnosis is only one. Okay, only one provisional diagnosis. You cannot have more than one. The different diagnosis can be another few. If you can, try to have around 3 possible differential diagnoses. And you must be able to justify why you came to this provisional and differential diagnosis. And this justification for your diagnosis must be purely from the symptoms and signs in that particular patient of yours. Okay, once you have some provisional diagnosis and differential diagnosis at hand, then the next step is to go for the investigations. Okay, I've listed here the investigations. Okay, first of all is the routine and basic investigation, baseline investigation of the blood and urine. Then come to diagnostic investigations of the blood and urine. For example, in a patient you suspect abdominal pain, you suspect acute pancreatitis, then serum amylase becomes a diagnostic test. The patient with chest pain, you suspect myocardial infarction, markers like troponin T becomes a diagnostic blood investigation. Next, you come to plain X-ray of the abdomen. Plain X-ray of the chest, abdomen, and sometimes in head injuries, you may want to do a skull X-ray. These are the commonly done plain X-rays in surgery. Ultrasound scan, USG, is also a very important preliminary sign, especially in abdominal cases. In fact, today, in surgery, abdominal cases in surgery, ultrasound has become the first line of preliminary investigation of the patient. Next, CT scan of the abdomen, head, or whichever part that you are dealing with. MRCP, okay, which is an MRI examination. ERCP, okay, which is usually done for pancreatic and hepatobiliary problems and patients with jaundice where you suspect obstruction of the bile ducts. Endoscopy is another very frequently done investigation these days, especially in surgery
very important is your upper GI and lower GI endoscopy, okay, known as OGDS and colonoscopy. These are very, very important and examinations today. Then special tests for certain cases where you may want to know patient having bleeding and the cause cannot be determined. They may want to do angiogram or venogram to rule out obstruction or DVT. So these are important special investigations which are done not for every case but as and when is required. Then under special investigations you have got biopsies, various types of biopsies, fine needle aspiration cytology or FNAC, true cut core biopsy, incisional as well as excisional biopsy of the lesion. These are some of the common investigations you must look into, and you don't need to do all this investigation for any one patient, but you choose the investigations. In general, the first 3 or 4 are the most commonly done in most cases of surgery, okay, until CT scan or maybe ultrasound, okay, and the rest is when necessary the patient has indications for the procedure. Okay, having done investigations, then you come to the final diagnosis. So investigations, the final diagnosis is only made after all the investigations and reports have been reviewed by you personally, okay? And if necessary, you may proceed to do true tissue diagnosis, like a biopsy, which I mentioned just now, wherever is possible. If biopsy is easily done, then go for a tissue diagnosis. Or in cases where it's not too risky to do a biopsy, like deep-seated lesions in the abdomen, to do a biopsy sometimes is not easy. It has got complications as well. So in such cases, then you may want to do diagnostic tests where relevant, such as angiograms, such as MRI, MRCPs. These are all when tissue diagnosis cannot be easily obtained. Once you got your diagnosis, treatment in most cases is not much of a problem. First, you have the medical and pharmacological methods of treatment, giving of drugs, okay, giving of medical maneuvers. These are important for initial treatment, especially in resuscitation. Conservative treatment is very, very important. Okay, in surgery, the pre-operative resuscitation is very important to stabilize the patient before his surgery. Next is the surgical procedures. Okay, and surgery nowadays has become very simplified. Okay, from very major surgeries, now we are trying to make the surgery as simple as possible. Okay, endoscopic surgery is minimally invasive. And then minimally invasive surgeries like laparoscopic procedures, and then finally open surgery, which is in most cases in surgery is laparotomy. Okay, so surgery, if possible, we do the least invasive, that is endoscopy, followed by laparoscopy, and finally, if everything fails, laparotomy may have to be done. Next, we go into the long term and treatment and follow-up of the patients. This is very, very important, especially in chronic cases, cancer cases. These are very important for long-term management and follow-up to detect complications or recurrence of the tumor. And finally, others like chemotherapy or radiotherapy in cases of malignancy.
Okay, in your clinical diagnosis, the method, the various steps they've taken into consideration to come to a clinical diagnosis. At the end of it, you must decide, okay, before what were you expected to learn from the case. Okay, the clinical diagnosis, the various steps in the diagnosis. From there, you must find out what were the steps were the expected to learn from this case. Secondly, did you achieve your target? And thirdly, what more have you got to do to learn more from this case? So these are the three things that you must bear in mind when you clerk a case. Okay, in part 3 of our session, I shall give you an example of a case scenario, how you should clerk a patient. And in this case, the problem is the patient comes with pain in the right lower quadrant or right iliac fossa. Okay, now I go through a simple clinical case scenario for practice. The patient is a 24-year-old man who presents with 2 days history of abdominal pain. The pain started in the central abdomen and has now become constant and shifted to the right iliac fossa. The patient has vomited twice and there is loss of appetite. His motions were loose today, but there was no associated rectal bleeding or constipation. He does not drink or smoke and was healthy before. On examination, the patient was in slight pain and had a temperature of 38.2 degrees Celsius and a pulse rate of 110 per minute. On examination of the abdomen is flat and moves well with respiration. He has localized tenderness and guarding in the right iliac fossa. The rest of the abdomen was soft and no mass were palpable. The liver and spleen were not enlarged. Okay, first come to chief complaint. The chief complaint of this 19-year-old man is a 2-day history of abdominal pain. Now, let's consider the possible common causes of acute abdominal pain in a 19-year-old man. And these are some of the common diagnoses that come to our mind. Acute appendicitis, acute gastritis, acute gastroenteritis, right ureteric colic, acute pancreatitis, acute cholecystitis, and peptic ulcer. In the present history of present illness, we are given more information about the pain. The pain started in the central abdomen and radiated to the right iliac fossa. The patient vomited twice and is off his food. His motions were loose, but there was no associated rectal bleeding. Okay, what are the pointers, the issues that can be obtained from this history and history of present illness? We have the positive symptoms and the negative symptoms, relevant negative symptoms. Positive symptoms, abdominal pain. Okay, of 2 days duration, associated with vomiting. Pain radiates from the center abdominal region to the right iliac fossa. Pain was associated with loss of weight and loose motions. And under the negative symptoms, there was no rectal bleeding. The further information that is needed from this patient is the nature of whether he had fever, whether there was vomiting contents. What were the contents of his vomiting? Was it blood? Was it coffee ground? And urinary symptoms. Were there any urinary symptoms? Hematuria, dysuria. Okay, these are the common issues or pointers that we can gain from the history. So from the history, chief complaint and the history, we can come to the few possible diagnoses. Acute appendicitis, acute pancreatitis, acute cholecystitis. And by exclusion, we can exclude acute gastroenteritis, right ureteric colic,
and acute gastritis. Now we come to the physical examination. The patient has a temperature of 37.8 degrees Celsius and a pulse rate of 110 per minute. On examination of his abdomen, he has localized tenderness and guarding in the right ilia fossa, and urine analysis is clear. Again, we summarize his physical findings or physical signs under these three categories. First, the positive signs. He is febrile with a temperature of 37.8, tachycardia 110 per minute, and there's localized tenderness and guarding in the right ilia fossa. So these were the positive signs that you get from the physical examination. The negative signs that you see in this patient are no epigastric tenderness or guarding, no lumbar tenderness, and the urine analysis was normal. Okay, these three are the negative signs which were not present in this patient, and that will exclude some of the other causes. And you want to know further, you want to know whether he had jaundice, whether he had pallor, and his hydration status, which were not mentioned in the history.
Okay, now the clinical summary of this patient is shown in this slide. Number 1, patient 24-year-old man with 2 days history of abdominal pain. Secondly, the pain started from the central abdomen and radiated to the right ilia fossa. Thirdly, associated with loss of weight, loss of appetite and vomiting, and loose stools, but no urinary symptoms. Number 4, on examination, he was febrile and tachycardic. And number 5, there's marked tenderness and guarding at the right ilia fossa.
Okay, so after the physical examination, we have come to the provisional diagnosis of acute appendicitis with the differential diagnosis of acute gastroenteritis and acute pancreatitis.
Okay, there are some special considerations of this abdominal pain in female patients. Okay, things that you have to exclude in female patients is ovulatory cyst, either it's a leaking or a ruptured ovarian cyst, especially corpus luteal cyst or a ovulatory cyst. Other conditions is menstrual problem, dysmenorrhea, a detailed menstrual history and history of amenorrhea is important. Pelvic inflammatory disease, PID. Ectopic pregnancy is of special importance in young women, and this is because sometimes it can be a real emergency, and also the presence of fibroid uterus. Okay, the most important condition in these patients is age. The age of the patient is a very important consideration in considering the various conditions that occur in female patients. Okay, what are the investigation needed for this patient? First of all, a full blood count, and you will look for leukocytosis. Urine analysis, you look for RBC and white PC. RBC to suggest hematuria and WBC to suggest infection. Ultrasound abdomen and pelvis, normally it should be normal, or it can reveal an enlarged appendix, or the other important thing is to exclude other pathologies in the pelvis, especially ureteric stone and gynae problems. CT scan may be necessary if the diagnosis is not very sure or very even with ultrasound. Okay, MRI is rarely indicated, but sometimes if you're thinking of other lumps in the abdomen which you are not sure whether it's related to appendix, then you may have to go for MRI.
Then go into the investigations. It is notable in these results of investigation, the white cell count is raised, suggesting some form of infection. The C-reactive protein also increased, which also suggests some acute inflammatory phase. So these together It comes under here. These are the pointers: leukocytosis and C-reactive protein, which suggests something infection or some inflammatory process that is going on. And the required or expected test, serum amylase, which is we assume must be normal. Urine analysis we are told is normal, and we would like to do an ultrasound of the abdomen and pelvis, which presumably is normal. If these are required tests are normal, and then with leukocytosis and C-reactive protein raised, will suggest as an inflammatory or infective cause as the cause of disease.
Okay, the investigations for this patient, the urine analysis was normal and the ultrasound was also normal. Okay, these are some pictures to show you the abnormal findings of the appendix on acute appendicitis on ultrasound. Okay, here this is an appendix which is enlarged, then surrounded by some fluid here. Okay, so this is an enlarged appendix with periappendicular edema. This is a clear-cut sign of acute appendicitis, which is also shown in this picture here. All right, enlarged appendix, periappendix fluid, suggesting it is inflamed. And thirdly, you can get a target sign. Okay, this is on cross-sectional view. You see the appendix is inflamed, surrounded by fluid here. So this is a target sign. So these are the signs when, if seen on ultrasound, are suggestive of acute appendicitis.
And among the three, you will have the final diagnosis will be acute appendicitis.
Okay, next we come to finally the treatment of the patient with the diagnosis of appendicitis. Generally, the management is to resuscitate the patient with intravenous fluid, antibiotics, and opiate analgesia, and then followed by appendicectomy, which is the treatment of choice. So these are details of the intravenous resuscitation, antibiotics, analgesics, and IV fluids. Then appendicectomy, and the most commonly done method is laparoscopic appendicectomy. So you must be able to know the differences or the advantages of one over the other. Okay, laparoscopic or open appendicectomy. And it is equally important is your post-operative care, control of pain, antibiotics, and also the when to start the patient orally. Okay, finally we come to the learning objectives which we had in mind. What were you expected to learn from this case? First is your analysis and significance of the symptoms. Did you achieve your target? Yes, we achieved to a certain degree. Secondly, to look for positive and relevant negative symptoms and signs. Did you achieve? Yes, but and no. Yes, but no in relevant negatives. There are some relevant negatives which we did not look into. Thirdly, deriving at a logical diagnosis. Answer is yes. We have to come to a logical diagnosis of acute appendicitis. Now in this patient, what more have you got to do? First, number one, there are three things we must do. Number one, read up more on the presenting features of acute appendicitis. Formulate an outline of the investigation and treatment for this patient. And finally, clerk another patient with similar complaints, so as to study or to know the various types of presentation of a simple case of acute appendicitis. Okay, we come to the end of today's lecture. I leave you with this slide with you for your reflection on the touch. Touch creates a healing bond in patient care between the healer and the patient. The touch also provides the utmost that is needed by the sick, that is reassurance. Touch can be used to bridge the emotional and physical gap between the physician and a patient. It can directly express care, compassion, and comfort. Okay, thank you for your patience and hope to see you again in another session.